Good morning, ladies and gentlemen. Today I'm going to deliver a talk on a very important aspect of dermatology, that is the use of topical, oral, and intravenous steroids. I am Professor Ashar Ahmed Mashood, and if you are hearing me, please subscribe to my channel, which is a non-commercial venture. Systemic corticosteroids. Corticosteroids are a group of drugs which are chemically related to hormones produced by the adrenal glands. All corticosteroids, both the natural ones and those which have been developed synthetically, share similar chemical structure. The corticosteroids have anti-inflammatory, immunosuppressive, anti-proliferative, and vasoconstrictive properties. Because the glucocorticoids inhibit some portion of immune response, they are used in the treatment of large number of autoimmune diseases. The glucocorticoid treatment is not a cure for any disease or condition, but it may be used as a suppressive or supportive treatment, which is life-saving in many diseases. So all these points are very important to register, as these points will be the basis of further build-up of knowledge regarding the steroids. Mechanism of actions. Glucocorticoids diffuses passively across the cellular membranes and binds to the intracellular glucocorticoid receptors, which are present in every cell. This complex, that is the steroid receptor complex, interacts with specific DNA sequences, resulting in either enhancement or suppression of transcription of particular genes. So the effect of corticosteroids is either by enhancement or suppression of the transcription of genes. This steroid receptor complex inhibits the synthesis of inflammatory cytokines, mainly by blocking the function of transcription factors such as nuclear factor kappa B. So the inflammatory cytokines are suppressed by the combination of steroid with intracellular receptors by blocking the function of transcription factors. Then the steroids also suppress the synthesis of cyclooxygenase 2, which is responsible for prostaglandin secretion in damaged tissue, and which leads to the inflammatory cytokine cascade. And by doing so, it inhibits the inflammation that is generated through the production of prostaglandins, which is one of the anti-inflammatory property of steroids. Then the steroids control or prevent inflammation by reversing the capillary permeability. That is, they causes the vasoconstriction and reduces the capillary permeability, suppressing the migration of fibroblasts and polymorphonuclear leukocytes, controlling the protein synthesis, and stabilizing the lysosomes at the cellular level. If the lysosomes are stabilized, they would not release the various cytokines or inflammatory mediators into the cytoplasm or extracellular. Then the steroid administration results in neutrophilic leukocytosis because the neutrophils are stopped from leaving the blood vessels. There will be a smaller elevation of monocytes as well, and there is a dramatic reduction in circulating eosinophils and lesser reduction in lymphocytes. So the increase in monocytes and neutrophils and reduction in eosinophils and lymphocytes in the circulation. Glucocorticoids impair a variety of T cell function and moderate to high doses, in moderate to high doses and induce T cell apoptosis, while keeping the B cell function and antibody production preserved. So the main effect of glucocorticoids is on cell-mediated immunity. Some of the important effects are the result of homeostatic response by insulin and glucagon. This is very important. Glucocorticoids stimulate the gluconeogenesis, resulting in elevated blood glucose levels, catabolism of muscle proteins and bone protein, and stimulation of insulin secretion. Because of high glucose level, insulin is produced. Both lipolysis and lipogenesis is stimulated, with a net increase in fat deposition in specific sites like face, shoulder, and back. Because of the protein catabolism or protein loss, skin undergo wasting, and catabolic effect of bone lead to osteoporosis. And in children, the corticosteroids will result in growth inhibition. So these are the main effects of glucocorticoids. Clinical indications of steroids. Acute anaphylactic reaction. For example, a bee sting or wasp sting or a drug reaction. Hydrocortisone, which is solocortive, is given intravenously in a dose of 100 to 200 milligram stat, with or without prior administration of epinephrine, adrenaline 0.5 mg intramuscular. In severe anaphylactic reaction, you need to give adrenaline in a dose of 0.5 mg intramuscular, and the hydrocortisone can be given before or after this epinephrine. Can be given without epinephrine as well. Acute self-limiting steroid-sensitive disorders like acute contact allergic dermatitis, then 1 week course of oral prednisolone will help, and reducing dose is sufficient. Then in acute generalized exfoliative dermatitis due to any drug, then steroid will also be very helpful. Autoimmune connective tissue diseases like SLE, dermatomyositis, polyarthritis nodosa, giant cell arthritis, or Wagner granulomatosis. Chronic disabling immunobullous disorders like pemphigus vulgaris, bullous pemphigoid, steroids are very useful. And number of miscellaneous disorders like severe lichen planus, pyoderma gangrenosum, and sarcoidosis. And systemic corticosteroids have an unproven value in erythema multiforme, Stevens-Johnson syndrome, toxic epidermal necrolysis, chronic urticaria, and cutaneous T-cell lymphoma. But even so, steroids are commonly used in all these conditions. Steroid preparations. So steroids are available. We are talking about systemic steroids as short-acting, intermediate-acting, and long-acting. So among the short-acting corticosteroids, or cortisone has both glucocorticoid and mineralocorticoid effects. It has the lowest potency of all the commercially available corticosteroids and short duration of actions. And it is appropriate for the replacement therapy in patients with adrenal insufficiency. So the commonly used short-acting corticosteroids is hydrocortisone or solocortif, having both glucocorticoid and mineralocorticoid effects. It is more potent than cortisone and has been somewhat longer duration of action. Although hydrocortisone may be used for systemic effect, it is most commonly used in skin emergency treatment, like acute urticaria or acute anaphylaxis. Intermediate-acting oral steroid is the prednisolone or delta-cortil, which differs only in the presence of hydroxyl or hydroxy group. This is the most widely used oral steroids, and it possesses 4 times the glucocorticoid potency than the natural corticosteroids, but has relatively less mineralocorticoid or salt-retaining activity than hydrocortisone and the cortisone. Intermediate-acting steroid injection. One of the very common preparation which is used in dermatology is the triamcinolone, Canacort A or Tricort, which is slightly more potent than prednisolone but has no sodium retaining, so no mineralocorticoid activity. And it is the most commonly given steroid injection. Another option for intramuscular intermediate acting steroid is the methylprednisolone or dipomedrol, which is similar to effect or similar in effect to triamcinolone. Long-acting steroids. The long-acting steroids include the dexamethasone or decadron, which is a potent glucocorticoid and no mineralocorticoid effect, and betamethasone, betnisol or betenolone, which is similar to dexamethasone in its effect. That is a potent glucocorticoid effect and no mineralocorticoid activity. Doses of systemic steroids. Steroid dosing is commonly characterized into a low dose, which is less than 10 milligram per day of prednisolone. So if you are giving 10 mg or 2 tablets of 5 mg prednisolone, you are in low dose. Medium dose is from 10 to 20 milligram of prednisolone. And high dose is anything more than 20 milligram of prednisolone per day. Then treatment for less than 1 month is called as the short-term treatment, and treatment for more than 3 months is called as the long-term treatment. So one classification is low dose, medium dose, or high dose, and another classification is short-term and long-term treatment. The long-term treatment is associated with several undesirable side effects, which we are going to discuss today. The corticosteroids for a few days are relatively safe, and there are less chances of any of the steroid-induced side effects. Excessive and prolonged corticosteroid use is one of the cause of iatrogenic Cushing syndrome. Routes of administration. The first is the intramuscular route. We have discussed about the intermediate acting injectable steroids given as intramuscular route, and the most commonly used is triamcinolone and other is the dipomedrol. And it is usually given intramuscular every 4 weeks. And this can cause marked hypothalamic pituitary suppression, severe local atrophic changes, and an event of untoward complication. The drug cannot be withdrawn promptly. So this is the disadvantage of intramuscular injection compared to the oral dose, that you cannot retrieve the steroid which has already been given. Pulse steroid therapy. We are going to discuss this pulse steroid therapy in detail later part of this lecture, and it is given as methylprednisolone solomedrol intravenously over 4 hours, and the dose is repeated according to various schedule, and it is given in severe bullous dermatosis or in autoimmune conditions. and the potential hazards are the thromboembolism, cardiac arrest, and psychosis. Intravenous steroid, that is the hydrocortisone, is useful in emergency treatment of acute anaphylaxis and urticaria. Oral steroids. The oral steroids may be taken as a single daily dose or using an alternate day regimen. For short-term use, that is less than a month, corticosteroids can be administered in 2 to 3 divided doses. And in most cases, the initial dose is anything between 5 to 60 milligram of prednisolone or its equivalent. For a prolonged use, for example, for more than 3 months, it is preferable to give corticosteroid as a single daily dose in the morning, because this is in accordance to the cortisol secretion in the body, because the maximum cortisol is secreted in the morning time. If you give the steroid in heavy doses in the evening, it will result in hypothalamic pituitary axis suppression. At this time, there is less pituitary adrenal suppression while therapeutic effect is maintained if you give in once a day dose in the morning. The oral steroids have sufficiently prolonged action to ensure sustained effectiveness of a single dose. So with the proper dose, good response is expected within 10 days. Once the response occurs, the dose should be carefully reduced to lowest possible dose that would offer an adequate control. If you are giving oral steroid for a steroid-responsive disease, never try to taper the steroid down and remove the steroid completely from the treatment, because this will result in flare of the disease. Always be patient and give steroid for a long period of time and taper slowly and gradually. I will let you know how to taper the steroid in this talk as well. The alternate day oral treatment. You may be asked about the benefit of alternate day steroid treatment with the daily steroid treatment in exam. So you should know that this is the method where there is the minimum effect of oral corticosteroids on the adrenal glands. Hence, patients who are taking steroid for a long period of time, alternate day treatment is a preferred way to treat. It is, however, not suited for control of severe acute illnesses for which daily dose is essential. So remember, the alternate day treatment is good for prolonged steroid use, and it is useful because it will cause less adrenal suppression, but it is not indicated for acute severe illnesses. Only long-acting corticosteroids such as prednisolone, prednisone, or betamethasone can be given for alternate day dosing. Conversion of daily to alternate day regimen should be carried out gradually rather than abruptly by progressive diminution of the dose on even number days and building of dose of odd number days. So I will give you an example how we can convert daily dose to alternate day dose. For example, if we are giving a patient 30 milligram of prednisolone daily and we intend to shift this 30 milligram to alternate day dose, what you will do is you will increase 5 mg dose on one day and decrease 5 mg dose on the other day. So how will we proceed? We'll give 35 mg next day, then 25 mg the other day, then 40 mg and 20 mg. Building 5 mg on one day and reducing 5 mg on the other day. Then 45 mg on one day and 15 mg next day. then 50 mg the other day, and 10 mg next day. So you can see that the dose is being built on one day and is reduced on the other day. Then 55 mg and 5 mg, then 60 milligram and no dose on the next day. And now we have shifted 30 mg to alternate day regimen, and that is 60 milligram. And 60 milligram on alternate days is equal to 30 mg daily. Then we would start reducing this alternate day dose to 50 mg, and next day no dose, then 50 mg, 55 mg, then 50 mg, then 45 mg. So we are going to reduce the steroids in alternate dose days, or we can stop reducing at a particular dose. For example, 20 mg, we can give it for a prolonged period of time. And in this way, we can shift daily dose to alternate day dose. The alternate day systemic steroid therapy is not always as effective as daily dose treatment when given in equivalent doses. I've already mentioned this, that in case of severe acute illnesses, you will always give a daily dose or a divided dose rather than giving on alternate dose, which is meant only for long-term use. Equivalent doses of corticosteroids. There are many corticosteroids in the market, and sometimes you have to interchange between the different steroid preparations. So what will be the formula? Prednisolone 5 mg is equal to prednisone 5 mg, and this is equivalent to dexamethasone 0.75 mg or betamethasone 0.6 mg. Both the dexamethasone and betamethasone tablets are available in 0.5 mg. So just remember that 5 mg of prednisolone is equal to 0.6 mg of betamethasone. So for the equivalence, calculate accordingly. Then methylprednisolone, which is the hydrocortisone, it is 4 mg. 4 mg is equal to 5 mg prednisolone. Triamcinolone 4 mg. Corticosteroid 25, cortisone 25 mg. And hydrocortisone is 20 mg. Tapering, which is also very important. In patients with long-term steroid treatment, gradual reduction of dose over several weeks prior to discontinuation is important because the abrupt reduction may lead to steroid withdrawal syndrome, which resembles the adrenocortical insufficiency. That is, the adrenocortical insufficiency occurs when heavy dose of corticosteroids are given for a prolonged period of time and then stopped immediately. The body, in such cases, has learned to use the systemically administered steroid, and the inherent or the inbuilt production of steroids is suppressed by that iatrogenic steroid therapy. So once you stop this iatrogenic steroid therapy, the body will take time for the production of inherent steroid. And till that time, the body will suffer from the steroid withdrawal symptoms. The tapering is dependent upon the disease for which the steroid is given, the clinical response, duration, and side effects. Dose may have to be increased if there is a flare-up of condition. So, and tapering should begin again, but then again at a slower rate. For example, if you are tapering 5 milligram weekly in a patient of pemphigus vulgaris, and once you reach a dose of 20 milligram, the patient has a flare of disease. You again increase the dose to 60 milligram. And once the disease is controlled again, now you are going to reduce the dose 5 mg after every 2 to 3 weeks. You will taper it more slowly. The dose may have to be increased. We have discussed this. So this is a steroid withdrawal protocol. If you are giving prednisolone as a dose more than 60 mg, then you can reduce 10 mg after every 3 weeks. We can do it like this, or we can reduce 5 mg after every 10 days. If you are giving prednisolone at a dose of 30 mg, then reduce 10 mg every month. That means reduction of 5 mg every 2 weeks. If you are giving prednisolone in a dose less than 30 mg, then taper 5 mg every 3 months. And if you are giving prednisolone to a dose of 20 mg, then taper by 2.5 mg every 3 months. So you can see through this protocol that tapering is never done hurriedly, and it is always done slowly and gradually so that the disease may not get flared and we don't have adrenal suppression. These are the symptoms which develop if prednisolone for a long period of time stopped too quickly. And the steroid withdrawal symptoms include severe fatigue, weakness, body and muscle ache, depression, dizziness, irritability, joint pain, loss of appetite, light-headedness, mood swings, nausea, and stomach pain. If you find the patient suffering from any of these symptoms, the answer is to restart the steroid. Side effects. All the following effects are seen on long-term steroid use. Fluid and electrolytes. There is sodium retention because of the mineralocorticoid effect, fluid retention due to sodium retention, congestive cardiac failure due to fluid retention, potassium loss due to mineralocorticoid effect, calcium loss, and hypertension. Calcium loss is because of the catabolic effect on the bone, and hypertension because of sodium retention. Then muscle and bone. There will be a muscle weakness, loss of muscle mass, osteoporosis, compression fracture of spine, aseptic necrosis of femoral and humeral heads, pathological fracture of long bones and tendon rupture. All of these are because of the protein catabolism, muscle catabolism, and bone catabolism. Skin. There will be easy bruising because of loss of collagen, resulting in more chances of vascular injuries, skin thinning, fragility, acneiform eruptions, stretch marks, hirsutism, and telangiectasias. Endocrine system. There will be menstrual irregularities. Many of the women will come to you and complain about their menstrual irregularity when you are giving them high-dose steroids. Development of Cushing state. Because of high-dose steroid, the patient developed this Cushing syndrome, the iatrogenic Cushing syndrome, which is quite obvious in patients on high doses of steroid like pemphigus patients. Then suppression of growth in children. If you are giving steroids in heavy doses to young children, there will be growth retardation. Decrease in carbohydrate tolerance because of increased glucogenesis. Manifestation of latent diabetes. The latent diabetes will become manifest while patient on steroids. Increased requirement of insulin. So patient is already diabetic, then the insulin requirement will increase. So you have to give or add oral hypoglycemic or have to give increased doses of oral hypoglycemics, and lipodystrophy may occur. Effects of steroids and nerves and central nervous system include convulsions, increased intracranial pressure with papilledema, which is called a pseudotumor cerebri, the dizziness and loss of balance and headache. So these all effects are seen when heavy dose of steroids are given, particularly when we are giving methylprednisolone as IV infusion. The common mood swings or mood disturbances include hypomania, euphoria, depression, psychosis, and delirium. These effects are quite common with oral steroids. Eyes. There is posterior subcapsular cataract, increased intraocular pressure, glaucoma, and bulging eyes, exophthalmos. The GI effect include peptic ulcer with possible perforation. So always give a proton pump inhibitor or some antacid with whenever you are giving oral or intravenous steroids. For there are chances of hemorrhage, pancreatitis, abdominal distension, and ulcerative esophagitis. What about the use of systemic corticosteroids in pregnancy? There is little concrete evidence that systemic corticosteroids are harmful in pregnancy. There are sporadic reports of stillbirth, spontaneous abortions, cleft palate associated with systemic corticosteroids. A recent review concluded that steroids are not teratogenic. So infants born to mothers who have received substantial doses of corticosteroids should be carefully observed for signs of hypoadrenalism. So they may be requiring maintenance steroid therapy. Very little corticosteroids enter the breast milk, so there is absolutely no harm in giving steroids to lactating women. Precautions. Because corticosteroids reduce the immune response, they should not be used in patients who have active fungal infection or tuberculosis. Similarly, patients on corticosteroids should avoid the live virus vaccine. Steroid may mask the signs of infection like fever, decrease the resistance and inability to localize infection. So usually the localized infection will become generalized if the patient is on steroids. So any evidence of infection should be treated promptly. Corticosteroids have been associated with increased risk of gastric ulcer mentioned before. Patient receiving the equivalent dose of prednisolone 7.5 mg day or more over 3 months should receive the prophylactic therapy to prevent bone resorption, such as calcium, biphosphonates like aldronate, etidronate, and residronate, and calcitriol. So remember, whenever you are giving or intend to give steroid for more than 3 months, always give some bone protection. Patient on long-term steroids must have a baseline plasma cortisol level, ACTH stimulation test, methylprednisolone test, or cortisol precursor level in the urine to estimate hypothalamic pituitary axis integrity. Now the topical corticosteroids, another very interesting subject because we dermatologists use topical steroids to the maximum. They are the mainstay of treatment of eczematous dermatosis and other inflammatory conditions, either regularly or occasionally. Modification to both the ring structure of steroid and the side chain change the specificity of action, the penetration, potency, and side effects of topical corticosteroids. This strategy leads to development of highly lipophilic compounds such as beta-methasone dipropionate and triamcinolone acetonide. In view of the great difference in potency between different corticosteroids, it is essential for the dermatologist to be able to rank or classify them by potency in order to predict the response and predict the possible adverse effects. The most widely used approach to compare the potency of topical corticosteroids is the vasoconstrictive assay. This depends upon the vasoconstrictive property of glucocorticoid, apparent and measurable as pallor of the skin. Typically, the pallor reach a peak at about 9 to 12 hours after application and then falls, initially fairly rapidly over the next 10 hours, then more slowly. So whenever you are asked in the exam about how we classify the topical steroids on the basis of potency, you are going to answer that it is in accordance to the vasoconstrictive assay, and we are going to apply the topical corticosteroid on the skin, and we would then measure the time at which the pallor is achieved. For a potent corticosteroids, it will be earlier. For less potent, it will be later. British National Formulary 4-point scale. So according to this scale, the steroids are classified as mild, moderate, potent, or very potent. Among the mildly potent is the cortisone acetonide, fludrocortisone, hydrocortisone, prednisolone, prednisolone acetonide, and tixocortol. So in this, we include hydrocortisone and adventin. Sorry, hydrocortisone only. Then moderately potent include fluocinolone acetonide, triamcinolone acetonide, Canacort or Canacomb. Potent include beta-methasone valerate, which is batnovate, dexamethasone sodium phosphate, fluticasone, which is cutivate, and methylprednisolone aceponate, which is adventin. So cutivate and adventin comes in the potent steroids. Very potent steroids include helsinonide Volog, which is not present in Pakistan nowadays, beta-methasone diapropionate, which is Provate or Senalar, then diaflucortilone, valerate, Narizone, which is less commonly available now, and then one of the most popular is clobetasol 17 propionate, Dermovate, Clobivate, or Clobiderm. Vehicle and formulations. So steroids are available in all the three vehicles, that is ointment, cream, and lotion. Ointments are helpful for dry chronic eczemas, while creams are more effective in acute and exudative eczemas. The lotions or gel or mousse form is effective for the scalp use. In case of localized disease like Pomphylix, a refractory plaque psoriasis on leg, or a patch of lichen sclerosus chronicus, or a prurigo, steroid is given under occlusion. That is, steroid is applied, ointment is applied, and polythene film or sheet is applied over it, which will simultaneously prevent the scratching and increase the drug penetration. So it is effective for all these indications as mentioned above. Several antimicrobial and antifungal agents like glycanol, clotrimazole, fusidic acid, miconazole, neomycin, nystatin are commercially formulated in combination with topical corticosteroids like Fusicord, Fusidin, Fudic Age, or Betnovate N. So Dermovate NN. So all these are the combination of antimicrobial, antifungal with steroids. These combinations are used when diagnosis is unclear in hope to cover all possibility. This approach is, however, not a recommended one, and a good dermatologist should be able to pick up the exact cause and give appropriate therapy, whether you are going to treat with antifungals, antimicrobial, or with steroid. The main disadvantage is the risk of obscuring the diagnosis when such combinations are used. Then steroids are also mixed with tar, salicylic acid, and calcipotriol, especially for use in chronic plaque psoriasis. Many dermatologists have found it useful to create their own formulations by diluting proprietary products or addition of other medicaments like sulfur, urea, lactic acid, menthol, tar, and salicylic acid with topical steroids, with Vaseline, emulsifying ointment, petroleum jelly, aqueous cream, etc. They are useful as many different effects may be achieved from a single preparation. And the most important is that there will be less chances of steroid-induced localized atrophy and localized side effects. And you can give the steroids over a long period of time with less side effects covering large areas of the body. But the stability of steroid in such formulations is unpredictable. So according to my observation, such preparations should not be used beyond 3 months of preparation. Another question which would be asked by the examiners in the exam and will you be confronted in your day-to-day use is the amount of ointments required for a particular patient. In general, no more than 45 to 60 gram of cream or ointment should be used each week, no matter what is the potency of corticosteroids. If you are advising a tube of a steroid to a patient, your take should be that this amount should not exceed 45 to 60 gram of cream or ointment. per week. Side effects are minimized and efficacy is increased when medication is applied for once or twice daily for 2 weeks, followed by 1 week of rest. This cyclic schedule or the pulse dosing is continued until the resolution is achieved. Intermittent dosing that once or twice a week can lead to prolonged remission of psoriasis if it is used in initial clearing. Alternatively, intermittent use of weak topical steroids can be used for maintenance. So either we can give intermittent dosing of potent topical steroids or intermittent use of weak topical steroids after the control of psoriasis. The fingertip unit and rule of hand provides the means to allow how much cream to be dispensed or given to the patient. A fingertip unit is the amount of ointment expressed from a tube with 5 millimeter diameter nozzle, which is the nozzle of most of the steroid creams and ointments, applied from the distal skin crease, as you can see in the picture, to the tip of the distal skin crease to the tip of the index finger. And one fingertip unit weighs approximately 0.05 gram of ointment or cream. This is the fingertip unit. Then rule of hand. The area of one side of hand is defined as the one hand area. One hand area of involved skin, the area of palm is 1% of the skin of the area of the body. Then one hand area involved required 5 fingertip unit or 0.25 gram of ointment for one application. This is how you can calculate with fingertip unit. That is for face and neck, 2.5 fingertip unit, 3 fingertip unit for each arm, 6 fingertip unit for each leg, 1 fingertip unit for each foot, 1 fingertip unit for each hand, and 7 fingertip unit for front or back and buttocks. 7 for front of the chest and abdomen, and 7 for the back and buttocks. Approximately 282 grams is required for twice daily application on total body surface for 1 week. If you are going to apply the ointment to whole of the body, then 282 grams of dispensed ointment is required. The amount of cream required to cover a certain area can be calculated by remembering that 1 gram of cream covers 100 square centimeter of the skin. The entire skin surface of every size adult is covered by 20 to 30 gram of cream. So a 20 gram or 30 gram of ointment should cover whole of the skin surface of an individual. Then intralesional steroid, which is also a very common practice in dermatology OPDs. Several dermatoses like alopecia areata, the keloids, lichen simplex, or nodular prurigo would require intralesional steroid. Triamcinolone is the most commonly used intralesional injection for intralesional steroids. Depot-withdrawal is not that effective for intralesional therapy. And the dose is 5 to 10 milligram per ml. Remember that triamcinolone is available as 40 mg per ml injection. So if you are going to prepare for 5 mg per ml, 10 mg per ml, then you have to take 25 units of triamcinolone in an insulin syringe, and rest of the 75 units you are going to take either normal saline or plain lignocaine. So this will make it as 10 milligram per ml solution. If you are going to give 5 mg per ml, then you are going to take 12.5 units of triamcinolone in an insulin syringe and rest either normal saline or lignocaine. Side effects may be localized dermal atrophy. If you give high dose of steroid more than 10 mg per ml and large amount of volume as well, and hypertrichosis and leukoderma. Side effects of topical corticosteroids are also many, and they are directly related to their potency. It is often appropriate to use more than one compound simultaneously so that mild or moderate steroids are used in areas such as face and genitals, and potent steroids are used on other areas. The most worrying is the cutaneous atrophy, since this may become permanent. Other problems include the development of contact allergy and risk of infection. While treating face, there is additional risk of inducing acneiform eruption, rosacea, perioral dermatitis, and hirsutism in female. Then steroid will also cause inhibition of the melanocyte function, and that's why they become part and parcel of many anti-melasma creams. And if the potent steroids are applied on skin, then they may give localized hypopigmentation, and which is especially seen with intralesional steroids, and when potent steroids are given under occlusion. Loss of connective tissue support because of steroid, because of effects on the collagen, will result in erythema, telangiectasias, and purpura, as there is less support of dermal vasculature. Locally applied corticosteroids have been demonstrated to impair wound healing and reepithelialization in a variety of animal and human models. So if you are doing invasive procedure, it is better not to give steroid after that. Cautions while using topical steroids. Potent steroids should not be used on the face, as I mentioned before, and should only used if we are treating for severe dermatosis like CDLE on the face. Caution is required when applying topical corticosteroids in the presence of infection, as there is a risk of exacerbation. And avoid topical corticosteroid in presence of active viral infection like herpes, wart, or molluscum. When dermatophyte infections are inadvertently treated with steroid, that is, the treating doctor is unaware that the patient is suffering from fungal infection, the sign and symptoms of fungal disease are masked transiently, and there is a partial improvement. And this condition is called asthenia incognito. And when the steroids are withdrawn, the disease gets exacerbated. Scabies, again, if it is wrongly diagnosed and treated with steroid, the pruritus is improved temporarily while the infestation persists, and unless scabicidal treatment is applied. So once the steroid is withdrawn, there is an exacerbation of scabies. Infantile gluteal granuloma are because of candida, and it is seen in infants who are treated with steroids for nappy rash. Then, since candida is already present in this area, so such patient develop these infantile gluteal granulomas. A well-known phenomenon encountered with topical steroid is tachyphylaxis, which means progressive decrease in response to topical steroids on successive applications. The solution is change of type of steroid. Rebound phenomena is of concern in management of psoriasis. In several cases, withdrawal of treatment with potent or very potent steroid is followed by eruption of severe generalized pustular psoriasis or unstable psoriasis. Suppression of pituitary adrenal axis by topical steroids. We see this effect mainly by oral or intravenous steroid, but if heavy dose of topical steroid, that is more than 50 grams of superpotent steroid is applied on the skin, then it can result in suppression of hypothalamic pituitary axis within 10 days of 2 weeks of use. Children and babies have high ratio of surface area to body volume, and they are more vulnerable to hypothalamic pituitary axis suppression as a result of increased systemic absorption of steroids. Then the last part of this talk is concerning methylprednisolone or solomedrol. The salient features. Methylprednisolone is an intermediate acting glucocorticoid. It has anti-inflammatory, immunosuppressive, anti-proliferative, and vasoconstrictive properties like any other steroids. Inhibits some portions of immune response, hence in large number of autoimmune diseases. And the half-life is 2 to 3 hours. So dermatological indication of methylprednisolone include atopic dermatitis, severe. You should add the word of severe with all these terms. Severe atopic dermatitis, severe contact dermatitis, severe pemphigus vulgaris or pemphigus foliaceus, severe bullous pemphigoid, severe erythema multiforme, Stevens-Johnson or 10, severe SLE, dermatomyositis, polyarteritis nodosa, giant cell arthritis, and Wagner granulomatosis. So you never give methylprednisolone to patients who are suffering from usual illnesses. We always give it to patients who are suffering from severe disease and who are life-threatening. Objectives and guidelines. Patient requiring methylprednisolone will have 3 doses or 5 doses, once daily infusion, and an overnight stay for observation is required. Methylprednisolone must not be given if there is any sign of acute infection and patient suffering from active peptic ulcer. Should not be given during pregnancy, should only be given during pregnancy after discussion with gynecologist. The dose varies depending upon the indication. The rheumatology indications are 10 to 30 milligram per kg per day, which is a maximum of 1 gram once daily for 3 days. Usually, the steroids are diluted 100 ml of sodium chloride and given intravenously over 60 minutes. For first infusion, keep the rate slow to 2 to 4 hours rather than 1 hour. Pre-infusion checklist. Clinically review to ensure the patient has no sign of active infection. Give regular medication including analgesia but omit oral steroids. Please confirm if oral steroids are given at home or prior to inpatient therapy. Monitor the baseline observation like pulse, blood pressure, temperature, urine analysis, and endorse it on the nursing documents. Before first infusion, full blood count, urea and electrolyte, LFT, CRP, and ESR, and varicella zoster virus status should all be checked. Blood taken for these tests preceding week. Preparation and administration. The reconstitutive vials with water for injection, usually the Pfizer solomedrol is provided in 2 concentrations, 40 mg per ml or 80 mg per ml. Inject the water against the wall of the vial and do not use the vial if vacuum is not present. Withdraw prescribed dose and dilute it in 100 ml of normal saline. Following reconstitution and dilution, infusion must be started immediately. Do not store any unused portion for reuse. The infusion should be administered via a volumetric pump or sterile IV set. And it is recommended to flush the cannula or the vein with 50 ml normal saline at the end of the infusion. Monitoring. While the patient is taking the pulse steroid therapy, he should be monitored closely. Observe the blood pressure, pulse, and temperature every 15 minutes during the infusion and 1 hour after the infusion. The urine pass should be checked for glucosuria. Observe the cannula site for extravasation and infusion of any change in color or consistency. In event of any reaction, stop the infusion and deal with the reaction. After infusion course, lies with the relevant team as to follow-up and blood monitoring. Treatment for infusion reaction. So we can expect hypertension or hypotension. tachycardia, blurring of the vision, flushing, sweating, although all are uncommon. But whenever such problem occur, stop the infusion immediately and inform the physician. The bad taste in mouth is common and it is recommended to suck on the mints. Then pain at the infusion site, slow rate or pain at the infusion site, the solution is slow the rate of infusion or dilute the drug further. Rather than 100 ml, make it 500 ml. If glycosuria is present, check the ketones level and discuss with clinicians. If there is anaphylactic reaction, discontinue the infusion and immediate medical attention according to ACLS guidelines. Contraindications. Methylprednisolone is contraindicated in patients with documented hypersensitivity to the drug or its components. Patient is suffering from systemic fungal infections. There is live attenuated virus vaccine given, idiopathic thrombocytopenic purpura, premature infants, and must be given with great caution in patients with peptic ulcer, heart disease, hypertension with heart failure, certain infections and illnesses like varicella zoster, tuberculosis, diabetes, osteoporosis, and glaucoma. Adverse effects. Repetition, hypertension, hypotension, tachycardia, blurred vision, flushing, sweating, metallic taste in mouth, glucosuria, mood change. Rarely seizures and psychotic episodes. Ophthalmic effects, increase in intraocular pressure and exophthalmos. CVS effect, fluid retention and hypertension. Premature atherosclerosis, arrhythmia and hyperlipidemia. GI effect, increased risk of gastritis, ulcer formation, and GI bleed. Bone and muscle effects like osteoporosis, osteonecrosis, and myopathy. Neuropsychiatric effects, mood disorders, psychosis, memory impairment. Endocrine, hyperglycemia, hypothalamic pituitary axis suppression. Immune system effect, more susceptibility to infection. Hematological effects, leukocytosis and neutrophilia. So this brings me to end of this talk. I hope my lecture was of benefit to you all, and I hope to see you next time with another edition of my talk. Goodbye and have a very good day.